In this presentation, I'm going to answer the question, what effects do stigma have on people with psychosis? I will first start by outlining some statistics on stigma, talk about definition and types of stigma. I will then focus on the effects of stigma, and since there are so many, I will zoom in on subjective well-being, employment and education, recovery, and risk of suicide. I will then speak about implications of this research, specifically talking about the intervention targets, and then I will discuss some of the directions of the future research. So let's start with statistics on stigma and definition. In this presentation, I'm going to answer the question, what effects do stigma have on people with psychosis? First of all, I will start by outlining statistics on stigma, its definition and types. I will then speak about the effects of stigma, and since there are so many, I will focus on subjective well-being, employment and education, recovery, and risk of suicide. I will then speak about implications of this research, specifically focusing on intervention targets, and then I will briefly outline some of the directions of future research. Firstly, it's important to note down that 87% of individuals with psychosis report experiencing stigma. So there is the majority of individuals who have been diagnosed with this condition. So it is really important to target it, especially because, as we will see later, it has so many effects on these individuals. But before we proceed, it's important to understand what stigma is. And really, stigma is complex and it arises from the co-occurrence of processes reflecting labeling, stereotyping, separation, status loss, and discrimination. So let's specifically discuss each one of these. Firstly, labeling. And that means that individual who has psychosis is labeled as psychotic or mentally ill and is essentially placed in a separate category from people who are perceived as being normal. Also, these individuals are stereotyped, so for example, they're being seen as dangerous. And also, they can be separated. So in the past, they would have been put in mental asylums, and these days, they might have access to different services to other individuals. Also, they might experience status loss. So in the social context, they might find it harder to establish themselves and connect to friends. And in employment context, they might find it harder to access good positions that are highly paid. And finally, they're being discriminated against. So on the individual level, they might not gain certain employment or might not be able to get a certain flat because they're being denied it due to their condition. And on a structural level, they might have access to poor services. So for example, because they are psychotic, their GPs will focus on their mental health condition and disregard their physical conditions. Now let's move on to the types of stigma. So that is really important to consider, since we now know that stigma is such a complicated concept. To add to the complexity, it has different types as well. So the first type is experienced stigma, then we have internalized or self-stigma, and the perceived stigma. Experienced stigma is by definition the actual experience of stigmatization or rejection, such as not being able to get the job. Internalized or self-stigma is when individual takes in that experience and starts taking it really personally, leading to shame, blame, hopelessness, and guilt due to illness. And perceived stigma is what individual thinks most people believe about stigmatized group and therefore him or her as part of the group. And that makes it difficult to be present with other people because one will assume that people will automatically assign labels such as psychotic or dangerous to them. So now let's move on to the effects of stigma, and this is really the core of this presentation. And there are so many different effects that stigma has on an individual. And here I'm going to discuss a couple of studies briefly and then zoom in on particular ones. Wood et al. Has this fascinating paper from 2015, which reviewed the qualitative evidence on stigma in psychosis, and it picked out the main themes that emerged in individuals who have been stigmatized, and these are themes like social exclusion, lack of understanding, inferiority and inequality, shame and secrecy. And this paper really shows the kind of feelings that emerge in an individual who has been stigmatized. But on the right-hand side of this slide, after the line, you can see a couple more papers. Some of these are also systematic reviews, and they looked at perhaps some of the more measurable and tangible effects that stigma has on an individual, such as reduced subjective quality of life, or reduced employment and education, or say depression and anxiety. And these are statistics that are more likely to be captured in a number of studies and research and say policy reviews. So these are particularly crucial, especially as we're going to briefly discuss the importance of economic analysis. So in terms of this presentation, because there are so many different effects of stigma, and it's really difficult to systematize this research, and there are so many different ways to approach it, I'm going to only focus on the few. Specifically, I'm going to talk about reduced subjective quality of life in individuals with psychosis. I'll talk about reduced employment and education opportunities. Then I will move on to pessimism about recovery and poor recovery in those individuals, and the suicidality. So firstly, the subjective well-being. So meta-analysis shows that there is a strong association between stigma and poor quality of life in psychosis. And in terms of the mechanisms of action, it seems like self-labeling leads to increased stigma stress, which is in turn associated with lower well-being and 1-year follow-up. So what that means is, if say today somebody is being given a diagnosis of psychosis and they self-label themselves as psychotic, that is associated with poor well-being in 1 year after receiving the diagnosis. So really, stigma is this mediator between diagnosis and lower well-being. Also, there are wide-ranging effects on employment and education, and the link has been shown in multiple studies. So, for example, the systematic review of 27 studies from 2011 has showed that there is negative effect of stigma on employment and income, and recent evidence of even more, 96 studies, supports this research as well. And also this paper by Beckering showed that not only those individuals with psychosis find it harder to gain employment, they also have lower well-being in their workplace as well. And in terms of more of the mechanism of how it happens, individuals with psychosis might avoid getting employment in the first place, or they might be reluctant to disclose their mental health condition, leading to them taking more unpaid leave. And also they might have increased work-related stress because of this double burden of work stress and also having to hide their condition. And together this can lead to reduced duration of employment. In terms of the recovery prospect, this is particularly important and interesting topic, and that is because stigma affects recovery on multiple levels. So firstly, it can be a barrier to help seeking in the first place, so individuals might not even reach out to their families and admit that they are having some issues. Also, perceived stigma can be related to longer duration of untreated psychosis, and we know from the past literature that duration of untreated psychosis is related to the prospect of recovery. So the longer the individual does not get help, the more likely it is that their recovery prospects will be poorer. And that is also the reason that the early intervention psychosis services have been created to reduce this DUP. And also internalized stigma reduces subjective recovery. So that is also important, because what this means is that even if individual recovers relatively well, just because they believe they are psychotic, just because they start believing and internalizing the stigma that something is inherently wrong with them, no matter how well they recover, they will feel like they're not doing so well. And now moving on to suicidality, particularly important topic. That is because 50% of individuals with psychosis experience suicidal ideation, and 30% will attempt suicide at some point in their lives. And in fact, in a cross-sectional study, suicide risk was strongly associated with internalized stigma. However, the issue with this study is because it's cross-sectional, it's really difficult to draw a causal link between internalized stigma and suicide risk. And that is because it could be that the causation goes into a different direction. So in fact, suicide attempts or thoughts about suicide might increase the internalization of stigma. However, to counteract that evidence, there is actually a longitudinal study showing that increased stigma stress predicts stronger suicidal ideation after 1 year. And that suggests that if individual has experienced more stigma stress at one time point, a year later they will have more suicidal ideation, suggesting that it is stigma that leads to suicidal ideation and not the other way around. And finally, let's speak about the implications of this research. So what really has to be a priority? So we have covered a couple of effects of stigma. So how do we even start to decouple those and make a change? So one could argue that because stigma is such a complicated concept that has downstream effects on so many aspects of lives of individuals with psychosis, it would make sense to focus on prevention rather than cure. So, for example, having more educational campaigns to reduce stigma. Alternatively, one could argue that cognitive appraisals of stigma can be targeted because we cannot fully eradicate stigma from society. Actually, having cognitive therapies or coping strategies for individuals with psychosis might reduce the internalization of stigma, hence reducing the negative effects that it has on them, such as suicide or reduction in subjective well-being. Also, the consequences of stigma can be targeted. So, for example, employment can be improved in individuals who are stigmatized. But really, this is up to debate as to what is more important. However, I believe that all of these have to be targeted at the same time in order to gain maximum effectiveness from stigma-related interventions. And that is because, as I've said, stigma has so many different effects on individual on so many different levels, and therefore all of these levels have to be targeted ideally at the same time. So let's zoom in on what are the possible interventions available to improve, to reduce the effects that stigma has on individuals with psychosis. So some effective interventions are, for example, time to change campaign, and it has been associated with a positive attitudes toward mental health illness. However, importantly, it did not increase the intended positive behavior. So if individual was asked what they think about individuals with psychosis, they would say, yeah, I understand it's not their fault and can happen to anybody, but that does not mean they would actually hire them following this time to change campaign. In terms of cognitive therapies, there is some evidence for their effectiveness in reducing the effects of stigma. And also it's been found that active rather than avoidant coping is more helpful in reducing the effects of stigma and improving subjective well-being. Importantly as well, individual placement and support schemes have been found to be extremely effective, and 69% of young people with first episode psychosis gain education and employment compared to 35% of controls following participation in these schemes. So they're extremely effective. And where they can really come in place is, for example, if time to change campaign can only improve positive attitudes but doesn't improve behavior, individual placement and support schemes can be used to actually make sure that employers hire individuals with psychosis, and together with cognitive therapies and strategies to improve active coping strategies, together these interventions can co-facilitate each other and make sure that individual is joining the workplace where there is less stigma, but also there is support from IPS, but in the addition, they're ready themselves, thanks to cognitive therapies, to face that stigma when it does come up. So what are the future directions of the research now that we have outlined some of the effects of stigma and how we could actually improve it? So in terms of the future research, one could be cognitive therapy. So it would be important to reduce the negative effects of stigma using them. However, there is still limited evidence as to what exactly works and how it works. Also, multiple stigma interventions have been found effective in suicide prevention, but not for psychosis, but in other mental health conditions. And multiple stigma is a really important concept because what it means for psychosis, for example, is that individual who say is psychotic could experience stigma because they're psychotic, but also if they're taking second generation antipsychotics, they're very likely to be overweight, so they can experience additional stigma because of being overweight. So if we only target stigma from psychosis, we're not fully addressing the problem. It's important to address both stigmas, and together it might actually improve their outcomes even further. Also, it is important to target stigma in carers because carers are often the ones bringing individuals to the services, and if they believe that psychosis is a problem that cannot be resolved, that there's no treatment available there, an individual cannot be helped, that they're less likely to bring the individuals to the early intervention psychosis service. And finally, economic cost analysis is extremely crucial and perhaps is often not talked about enough. And that is because if we cannot show how exactly those stigma interventions work and what is the pathway between addressing stigma to improving the outcomes in those individuals. And if we cannot show exactly how these interventions translate into improved economic outcomes, then the funding will not be available for these stigma interventions to become more widely available. So thank you so much for your attention, and here are my references.